Department on Antimicrobial Resistance and Veterinary Products.
Thank you very much, Elizabeth. And unfortunately, we do not have anyone from UNEP because they had like other commitments at this time. Just also because I forget to introduce myself, my name is Francesca Latronico. I'm a veterinarian and I work at the Food and Agriculture Organization of the United States in headquarters Rome as AMR Laboratory and Research Activity Coordination. So happy to have you here. And now I pass the floor to Elizabeth, which will give the presentation. Over to you.
Yeah, it's my turn to make the presentation. Several of you have assisted already to several other webinars. We have been making the first one on the overall best 10 priorities that we found. We have made the one on transmission, and we're now on the third webinar, which will focus on integrated surveillance. I have added the link to the priority agenda. That is always interesting to see, because we can also only give an overview and not go very deep into details. And that also, as it is the third one, I have basically, we have changed a bit. I will start with the results of this integrated surveillance pillar and then go to methodology, because there's an appendix. You can look at details, and for the ones that have been to several webinars, that might be sort of a bit too much repetition. Nevertheless, we need to start with the definition of One Health, because there were a lot of discussions, as you can imagine, and we have now an official definition from the organizations that is coming from the One Health high-level panel. That you can have the whole sentences here, but for sure, One Health is integrated, unifying approach, and that aims to keep this sustainable balance between health of people, animals, and ecosystems. And this is really something, I'm a veterinarian, as you can imagine from the organization. I think it's really a recognition of the interconnection between health of animals, humans, plants, and the wider environment. And this interaction and link is also reflecting in our research agenda. For sure, it mobilizes multiple sectors, disciplines, and communities to work together, and contributes at the end to a sustainable development. But it's also a learning process, and I will try to use some of our experiences also when I present the results. This is not new. I mean, that the request to have something on research on One Health is not a new thing. We started, I think there was a big agreement in the Global Action Plan that the organization have made together in 2015. I think there's quite a long way that we have done together since. You had the more political EICG results and report. That was really important for us, because we also need to reach a political level when we want to get some attention to One Health research. Then for sure, the whole work is embedded in the quadripartite organization. We have a strategic framework that was published in 2022, and that we will renew for the next time. And the result is our One Health priority research agenda on antimicrobial resistance. What is the aim of the agenda? To catalyze interest among us researchers and donors on this quite new One Health topic, which is always complex, but that's the reality, especially on antimicrobial resistance. So we hope to really interest and give some guidance on what we think is lacking to make progress. So it's also the direction for investment, and really with focus on low and middle income countries, because we know and all have the experience that there's a lot of knowledge that's already ongoing in the advanced countries, on the richer countries, or in EU especially also. But this is not always easy to apply in the same way in low and middle income countries. So we really want to focus on this. So the identification or prioritization of research areas in the interface of One Health that should then inform policy and practice evidence in the future. The scope. It is a global exercise, so that's also a limit. It is focusing on interface on the One Health sectors. So we know that our sector priority research agendas existing, and each sector has its own advanced, but we really want to focus on the interface, because that is something that we think that has been a bit neglected, and that we want to be, everybody speaks about One Health. We want to keep a bit of flesh on the bone on what this could be. So we have focusing on bacteria, parasites and fungi. You know, for example, in the veterinary world, parasites is a big problem. In the human and plant side, fungi is probably at least equally or more important. And we want to build in our aim within the time frame of the SDG, the Sustainable Development Goals for 2030. What is out of the scope? And that might be partly explained on this existing sector-specific agendas that exist already. It's research and development of new antibiotics or the antimicrobials and vaccines, the diagnostics development, and the research that is related only one sector. I mean, for obvious reasons, this is important, but we did not include this in our research agenda. This slide is basically giving an overview on process and timeline. I will focus now on the timeline part, because there was first part of work to determine research areas. Then the second one, we saw the Delphi process with the experts and the meeting of the experts. That did lead to the official launch in June 23. And now we have started with the technical webinars focusing on each of the pillars of the research agenda. Now, when I go to the results to the integrated surveillance, it's focusing on cross-sector surveillance to improve common technical understanding, to generate and exchange information about antimicrobial use and antimicrobial resistance, and that between the sectors. What was also included was issues about harmonization, effectiveness, and implementation. The applicability in low and middle income countries, this is really an important part, and innovation for antimicrobial resistance surveillance that would be relevant to One Health. And I think maybe there's still, we would need an update maybe in 1 year, because I think a lot of things are ongoing in this area that might come with the new technologies. But anyway, that we'll see how we can go on this one. So the results was interesting because integrated surveillance is not something new. Some of you know that AGISA, we have worked on this for a long, long time. So it is quite a matured pillar. The outcome of the exercise was 11 research areas, and we presented them in 3 categories. Methodology development, the majority of this. Operational research, you see not that much was thinking that we still need this, and evaluation. And I think that's also interesting when we compare the different pillars, because you see the differences in each of the pillars in what is seen as most needed and what is seen as already more or less knowledge existing. I will go through these results 2 by 2, because I think it's really important to see what came out, this on the wording and also as a compromise sometimes, or the discussion of the experts. And that's important because we have really been looking to get the agreement, understanding, and the wide input from everybody. So we are really about the optimum strategies and minimum standards for adequate laboratory and resource capacity. That is really one thing that laboratory, I think that is on AMR. What do you need to really be able to maintain the quality and make this happening? How can existing antimicrobial resistance and use surveillance data from humans, animal, plants, and the environment be triangulated to allow early identification of the development and escalation of circulation? I think that's important. We had a lot of discussions about how to identify something new coming up, what would be the best way to go, and how to integrate this without to make too many special research questions. But I think that will be interesting when we go to the details on the results. Again, methodology. That's really what is the minimum feasible, representative, and meaningful antimicrobial resistance and antimicrobial use package to monitor and survey antimicrobial use and resistance in low and middle income countries. Again, most of the experience is coming probably from Europe or Canada for sure. Caroli will tell us about something, or Japan. but how can this, what is really the way to start to make it still meaningful? And then what are the highest quality, lowest cost, and most reliable approaches for sharing the data on antimicrobial resistance and use in a standardized format, so that things can be compared over the years, but also between the countries. Then next thing, also methodology still. What targets, methods, and data reporting formats would most comprehensively characterize the risk of evaluation circulation? Again, how can we tackle this, finding out something new that's coming up? That would be really an important question while keeping an ongoing surveillance. And then how can priorities for implementation of integrated antimicrobial resistance and use surveillance components be identified and set up, and to address a current research gap? So how we can make prioritization within this area. Then again, something we discussed, what is a hotspot? We didn't really have a very clear answer to this, I think, but it's how can antimicrobial hotspots be proactively identified and mitigated using a One Health approach? And then what are the priority opportunities for environmentally and financially sustainable innovation in integrated surveillance? Again, we also have the word of sustainable. This is also important because I think this needs to be matured in each of the countries, set up and be sustainable. Otherwise, this integrated surveillance will not make that much help. Also, the second part, we only have 2 questions on operational research, because in many countries there's already some experience. And that you see how can the limited availability of data from integrated multisectoral antimicrobial resistance surveillance programs be addressed in low and middle income countries? What can we tell them to make it really sustainable, not to cost efficient, but still meaningful? And how can the results be used in practical means by countries and regions? That's also what can we do with the data that we get. So that were our research question. And then at the end, how can we evaluate, to monitor and evaluate these integrated surveillance frameworks in different low and middle income countries? And here again, I think there's something about harmonization. What can we do meaningful to also learn from each other, while we recognize that each situation and each country has a different experience, different possibilities. I will now quickly go to the methodology. How did we come to these results? And again, overall on all the pillars, we had 62 research areas identified, 11 were attributed to integrated surveillance. And in the report, you have an appendix that gives the detailed methodology of the way we came to these results. So I will just take a very quick go over the methodology we used. And I took again the same slide, just going now to the process. This started with a scoping review from academic knowledge. Then there was the open call, and that was interesting because we wanted to get really the meaning and input from very different participants and stakeholders. So this was an open call that did allow to everybody to participate. And then the third part of this preparation work for the Delphi was the Gray literature review and survey analysis that was done by NOSL, so with the help from an outside organization in collaboration for sure with us. And from the results from these 3 parts of work ended up in the Delphi to prepare the Delphi panel. There we had the 3 rounds. That's, I think, quite usual. And then we also wanted to discuss with the experts the results, because in the panel, in the Delphi, everybody works on his own. So we really wanted to discuss, and that's the way we came to the very final wording, also the words that are in bold that you have seen. This was a decision and made by the experts in these discussion meetings at the end. And we, as a whole, for all the pillars, we had 89 experts. And now we are with our published results. Why did we use Delphi? I mean, I think Delphi is something, sorry, something recognized by most of the people in the world. It was easy also to do within the COVID time, and we had also. No, I can't. Okay, sorry for this. No, I do something wrong. We need, Jorge, we need to help. Jorge, can you? Oh, no, it's
Yes.
up. Does it work? No, it doesn't.
Not
Can you
yet.
please go to the next slide for Delphi method criteria? I don't know what's happened.
Yes, for sure. Can you see my screen?
Yes, it's okay.
It's okay?
Yeah. So, sorry for this. We had 154 research questions that were generated from this process, for the Delphi process, the question that we submitted to the panel. And then we had 5 criteria that were for the prioritization. Is the research important? Will the research strengthen capacity? Will it be inclusive? Will it be impactful? And will it be actionable in low and middle income countries? So these 5 criteria were applied to all the panels. Next slide, please. We had the 3 rounds for the Delphi. So from all the experts, we had not always each expert could participate to all the rounds, but we started with 17 of the 22 experts to look at 17 research questions that they had to use against these 5 criteria. In the second round, we dropped the one on importance, and we had 13 experts that had to basically deal with the 19 questions because there were questions added from the first panel. And the last panel, where 70 experts participated, they had to look at the 14 research questions that were coming from the second round and to select the top 10 without an order, just to tell what is in and what is out for top 10. Next slide, please. So we came up with this wording of the 11 research priority agendas areas that I have detailed before. We have established these reporting categories. I've already told the methodology development, operational research, and evaluation. Also because there's a timeline. I mean, if you have nothing before, evaluation might not be very meaningful if you don't have results. So it gives a different way and look at the results that we used, and also in accordance and agreement with the experts. Next slide, please. So what are the next steps? Now we have the result. We try to disseminate this through the webinars, but we will need to get a bit more into details. This is a global exercise, and we need to get this a bit down to the regions and also to national research agendas, because we are for sure, we come with a global look and it has to be adapted to the reality of each of the regions, but also each of the countries. We hope to get donor engagement and interest the experts and the scientific community. The webinars hopefully speak to our audience here, because that's really what we think, that we try to do an exercise that is helpful to give some guidance, even if needed to be adapted, and then bring it down to the research in a community in each of the countries. So we hope very much that we come from global to regional and to countries, and we get the interest in this quite new area of research. So we hope also to have it with the help of the existing networks, also our collaborating centers and reference laboratories, and for sure the community that we hope to interest here through our webinars. Next slide, please. I give with this back to Francesca, because that's the next dates for our next pillars. And we will hopefully have time to questions. And if you have any questions, you can contact us. You have our contact details here. Either of us, we work together in a at least weekly meetings. So each of us can answer. And thank you very much for your attention.
Thank you very much, Elisabeth. And then, yes, this is already like reminding what will be the next webinar, so which will go in the intervention pillar and will be the 7th of February. But now I pass it to Jorge, which will moderate and introduce the panelists, which have kindly accepted to participate. Over to you, Jorge.
Thank you, Francesca. And thank you, Elizabeth, for the clear presentation. Let's move on to the discussion panel. It's a pleasure for me to moderate this discussion panel. We have 5 experts with extended experience in integrated surveillance of AMR. Thank you to all of them for sharing this experience on this topic. I would like to start to introduce our first panelist, Sabiha Esak. Sabiha is the South African Research Chair in the Antibiotic Resistant and One Health and Professor in Pharmaceutical Sciences at the University of the KwaZulu-Natal in Durban, South Africa. She is also the chair of the WHO Strategic and Technical Advisory Group for Antimicrobial Resistance and also co-chair of the Quadripartite Technical Group on Integrated Surveillance. And she is a senior implementation research advisor to the International Center for Antimicrobial Resistance Solutions, ICARS. Thank you so much, Sabiha, for joining and sharing your experience. I have this first question. What do you consider are the main challenges of integrated surveillance in low and middle income countries? And how can research help to solve them?
Thank you very much, Jorge, for that kind introduction. Good morning, good afternoon, good evening, colleagues. Thank you for inviting me to be part of this important conversation. As the first speaker, I thought that I would begin by briefly describing what we mean by integrated surveillance. Now, integration can occur at 2 levels. Firstly, the integration of antimicrobial resistance and antimicrobial use surveillance data in single sectors. And secondly, the integration of AMR and AMU data, surveillance data across sectors. Now, the first AMR and AMU surveillance data are analyzed and reported together in a particular sector, one, either humans, animals, plants, or the environment. But in the second, AMR and AMU surveillance data is consultatively and collaboratively generated, analyzed, and reported in a coordinated manner across sectors. So we have single sector versus across sectors. Now, what are the challenges of integrated surveillance in LMICs? Those of you that follow the maps of the track surveys will know that most LMICs have established AMR and to a lesser extent AMU surveillance in human health. A substantive number of countries have initiated AMR and AMU surveillance in food animals, while surveillance in plants and the environment is in its infancy or yet to be implemented. And we've just completed a UNEP Afro workshop over the last 2 days, where we are now charting a plan for environmental AMR surveillance in Africa. So surveillance is undertaken in sector silos in the vast majority of LMICs with minimal integration and triangulation of AMR and AMU trends within as well as across sectors. And there is really minimal analysis at the interfaces. So integrated surveillance is very much in its infancy in low and middle income countries. The second part of your question, Jorge, is how can research help resolve these challenges? And here I want to strongly advocate for implementation research. So we know that the WHO, the FAO, and OHPRA have developed sector-specific AMR and AMU surveillance guidelines and data sharing platforms. The technical group on integrated surveillance is in the process of developing guidance on AMR and AMU integrated surveillance. And this is really a how-to guide, how to conduct integrated surveillance. And we know that a number of LMICs have also implemented the Tricycle project, which is a precursor to integrated surveillance. And the lessons learned from all of these have to be adapted to country contexts and to the resource constraints that are experienced by specifically low and middle income countries. And context and resources play a really important role in implementation research. And just to define implementation research, it is a scientific inquiry into questions concerning implementation, the act of carrying an intention into effect. And these could be in health research, policies, programs, or individual practices. So an integrated surveillance program and how it's implemented can form the part of an implementation research project. Just 2 more things to mention regarding implementation research, that it considers context and stakeholder mapping and engagement right from the inception to facilitate the ownership for the development, implementation, monitoring, and evaluation of integrated surveillance. Implementation research also includes implementation outcomes, and it measures such things as acceptability, adoption, appropriateness, cost effectiveness, coverage, feasibility, and sustainability. So all of these aspects will be covered when we're thinking about integrated surveillance in resource-constrained settings. And as Elizabeth mentioned in her presentation, implementation research is key to the operational research questions of the One Health Priority Research Agenda. Thank you, Jorge.
Jorge, you are mute.
You are mute, Jorge.
Thank you very much, and sorry about that. Thank you, Sabiha. I agree with you. I think that integrated surveillance is still in infancy in low and middle income countries. But it's also an opportunity because they are building the capacity by each sector. So they need to think how to integrate these different sectors and work on this integrated surveillance. Thank you again. I will move to the next panelist, is Carolee Carson. Carolee is a veterinarian and epidemiologist working for the Public Health Agency of Canada. She has more than 20 years of experience with integrated surveillance, antimicrobial resistant risk assessment, and linking science to policy for data arising from the Canadian Integrated Program for Antimicrobial Resistant Surveillance, CIPARS. In addition, she has published over 50 manuscripts, mentored more than 30 university students, and has worked on various international committees on a standard setting for AMU and AMR surveillance. Thank you, Carolee, for joining and for sharing your experience. Based on that, the question for you, what is your experience regarding implementing integrated surveillance and how research can complement the implementation? Over to you.
Thank you very much. Good morning, good afternoon, and good evening, everyone. It's such a pleasure to be here today to talk about this important topic. So for Canada, research was critical for both launching as well as it continues to be critical for refining our integrated surveillance program over time. So we actually started our integrated surveillance program by launching research pilot projects and field studies in the major food animal species in the late 1990s. And that was prior to the formal launching of our Canadian Integrated Program for Antimicrobial Resistance Surveillance in 2002. On the resistance side, when we started, we looked at what data, samples, and infrastructure were already in existence at that time. And we explored whether those samples or isolates that were being collected would be suitable for our needs for AMR surveillance. And in some cases, they weren't, which meant we had to collect the samples or develop the infrastructure ourselves. So a notable example of this was for our abattoir surveillance program, which is where we sample healthy animals at the slaughter plant. And we started out with this by doing a pilot research project using existing isolates that were collected for an export program. And this research pilot created working relationships between industry, the lab, and our surveillance program. Though at the end, what happened was the number of isolates was not enough for our surveillance purposes. And the isolates, the type that they collected were from carcass swabs or rinses, which is really good for understanding what is happening for transmission at the slaughter plant or during lairage. But we were more interested with what was happening at farm at the time. So we had to change the sample type to cecal content. But the research itself was so critical for establishing the relationships and understanding the infrastructure of where we could change things to maybe have our samples collected. On the antimicrobial use side of things, we mapped its system of how antimicrobials were distributed in our country, how they came in, were imported, how they were manufactured, whether they went through wholesalers, whether they went through feed mills to the veterinarians to the farms, as well as what was happening in human community pharmacies and in the hospitals. And research was essential to all of this. And it ranged all the way from what I would consider the micro work, such as using new techniques like whole genome sequencing to understand the similarity of the isolates as they're moving through the food chain to people, and also how to report that information in ways that our target audiences would understand. To very broad macro research, where we looked at the overall ecology or system of antimicrobial resistance to make sure we weren't missing something that we were unaware of that might be important from a surveillance context. So a lot of the research was either intended to inform our surveillance development or refinement, but we also found that in reporting or analyzing the surveillance data, questions came up. And to address those questions, when we had the infrastructure in place, we launched research projects. So it was a nice interconnection between them. For example, some of the pilot studies we did on farm for sample collection, we did those in order to do the best methodology with the resources we had. So where was clustering occurring with these isolates? Should we sample more pens on a farm, or do we include more farms in that region with the resources we had? And how to get the most representative samples for our purposes. We also did pilot studies to see if a certain food animal species or commodity should be included in our core surveillance activity. So that helped us with priority setting over time. And we also explored things like wildlife, rodents, so rats in urban centers, or additional food sources such as country foods, which in our northern region, these are foods that are acquired from hunting, trapping, or fishing. And on a personal, my PhD research was actually one of the pilot studies where I did a field study looking at beef cattle farms on how to best collect antimicrobial use information, whether it was farmer records, I developed a treatment manual for them, or collecting empty medication containers from the farmers. What was the most accurate, reliable, and easy thing for the farmers to do? And I also collected fecal samples on the farms to assess the relationships between what I found on use and resistance arising on those farms. So in conclusion, I would say that research certainly informed our surveillance activities, and then also the questions that came out of surveillance were turned back into research projects. Thanks.
Thank you very much, Carolee. I like the approach. I think was really interesting. And because the quadripartite agencies have also worked on that to develop some models for integrated surveillance. But it's interesting to see how the research can complement. The first approach that you've taken was used to write some additional question that is shaping the system. So this is interesting because for low and middle income countries, when they are establishing this collaboration, it's interesting to work together, and these questions are coming. And the tricycle that was mentioned is one of these models. Thank you, Carolee. I will move to Philip Taylor. Philip is gained first-class honor in the plant science and PhD in plant pathology from the John Innes Institute in England. He then pursued an academic career for several years before becoming a farmer, where he grew organic, GM, and conventional crops. Thereafter, another change of direction took him to the CABI, where he became an important member of the PlantWise program, taking charge of the training material and subsequent training to overseas extension workers. Thank you, Phil. I think that you are complementing this. You know, integrated surveillance has been focused on the food chain. So the sectors more involved or more developed has been the animal, food, and human. But now we have this One Health that is including the plant sector. So we would like to hear from you. What are the most relevant research priorities to foster the integration of the plant sector and integrated surveillance? Over to you.
Well, thank you very much for the invitation to talk, and hello to everyone who's listening. I'd just like to acknowledge the fact there's been a sea change in the thinking of this, and as you said, Jorge, the inclusion of plants in the One Health AMR debate has been a great thing. And looking at the transition of how plants are represented in the document that Elizabeth showed us, initially plants were almost excluded, but now plants are firm and central within the quadripartite AMR. And so I'd like to As a relative newcomer to the whole debate, the AMR debate, on behalf of the plant community and the crop community, I'd like to thank the existing members for their welcome to this difficult concept of plants and crops. So I've been made feel very welcome in this debate. Sometimes it seems as though the more you know about something, the more complicated it becomes. And this is certainly the case with the inclusion of AMR in crops into the whole AMR One Health. And there's so much that we don't know, it's difficult to know where to look to see what it's difficult to know where to look to find out the answers we want to. But breaking down AMR with crops into 4 different areas. The first one is the concept that human pathogens are turning up resistant to antibiotics in soils and on crops, and people are eating them, and people are being sick, becoming sick with antimicrobial resistance microorganisms. And we can talk about where these antimicrobial resistance bacteria have come from, but this is one aspect of AMR in crops. Of course, it's exacerbated when people eat crops raw, salad crops, for example, where opposed to crops which are boiled or processed before they're eaten. Another aspect of AMR is the use of antibiotics on crops deliberately to control plant pathogens. And now the biggest example of this is probably citrus diseases, people applying streptomycin onto citrus to control diseases. And of course, unsurprisingly, resistance develops and you get resistant plant pathogens. And of course, then the question is, to what extent do those resistant plant pathogens pass on this resistance to other bacteria, such as human pathogens that might be around? And then leaving beside bacterial pathogens, moving on to fungal pathogens, as one of the previous speakers said, there are far more fungal pathogens of plants than there are bacterial pathogens. And this is the area where there are fungal pathogens of people and fungal pathogens of plants, and there is a crossover between the two, and I'll come back more to that in a moment. And finally, there's the resistance of fungal pathogens to fungicides, an entirely crop-related area where there is no medical or veterinary inclusion at all. But of course, to be truly comprehensive in the AMR One Health, this has to be included, whilst on the other hand, we need to acknowledge it is rather separate as well. So where are the research priorities, and how do we include crops into integrated surveillance? Well, just going back to the first one, the concept of antibiotic resistant bacteria in the soil is an important aspect to measure and to monitor. And I think it would be extremely important for countries to monitor the amount of antimicrobial resistant bacteria in their soil. Once you've done that and you can get a measure of it, you can find out where these are coming from or why they're developing and how long that they will survive in the soil. But this is essential. And my work, which looked at antibiotic use on crops, showed that there was no use of antibiotics on crops in Africa. At least we found none. And yet the research by Ariel Brunn, she did a meta-analysis. She was finding a great deal of antimicrobial resistant human pathogens in soils. So that would indicate that it isn't the use of antibiotics which is leading to these resistant bugs developing. So that's an important aspect of what needs to be looked at. Another aspect which we don't fully understand is that are the mechanisms of resistance in the soil the same as mechanisms of resistance in hospitals? Whilst it's very easy to buy some vegetables, to wash off the outside and plate it out on media containing antibiotics and then count the number of survivors. This is a very easy thing to do, and people do it all the time. But mechanisms of resistance is much more difficult. So we need to see, are the mechanisms of resistance in the soil the same as the ones in hospitals? And whilst not surveillance, that's an important aspect of the research. We also need to track where these bacteria are coming from. As I said, are they developing in the soil? Are they coming from hospitals directly? And Of course, the bacteria in the soil are in an environment which they've never been in before, haven't naturally evolved in, and they're coming up against many different agrochemicals, and it's been shown that herbicides can increase the resistance of these bacteria hugely. And so maybe we need to look at herbicides and the antimicrobial development of antimicrobial resistance, and to see whether the same mechanisms of resistance are occurring in both scenarios. We also need to investigate the transfer of AMR resistance from plant pathogens to human pathogens, because this hasn't been looked at and we don't know how much that takes place. So the kind of bacteria which plant pathologists are familiar with is Xanthomonas, Pseudomonas, Owinia, Ralstonia. These are all familiar bacterial names for a plant pathologist, but to what extent can they pass their resistance genes to the human pathogens that you know, that you're more familiar with than I am? And so there has been some research to show that the amount of antimicrobial resistance in orchards where antibiotics have been used is less than those where they haven't been used, which is rather counterintuitive. You'd expect the amount of resistance to increase, and yet the results seem to indicate that's not the case. But the big one that I think people are very concerned about is the development of fungal pathogens which are resistant to antimicrobial fungicides. So the Dutch bulb industry, Aspergillus fumigatus, which has become resistant to the triazoles through the extensive use of the chemical in the Dutch bulb industry, has been a wake-up call to the world. And increasingly, there are more fungal diseases which are becoming diseases of plants and diseases of fungi. And this is something which we need to look out for. And if anything, there is a hotspot, this should be the hotspot that we should look for. And so, for example, I'm an editor of a new disease report, and there's a fungus called Curvularia alcornii, which was only discovered in 2012 in Thailand, but in 2021 it was found to be a human pathogen in North Carolina, affecting a patient, and in 2022 it was a plant pathogen infecting tomatoes. So this fungus has arisen from nowhere, and it's now affecting people and plants as well. So this is the fungi are changing, the fungi are on the move, and we need to make sure that we monitor them and watch out for the resistance of them to the chemicals that we use to control them. And then finally, there's the case of the plant pathogens, which are solely plant pathogens. And this is something which has been sorely underfunded, and the amount of surveillance has been very poor, even in the high-income countries. And we need to monitor the amount of resistance that these plant pathogens have to a much greater extent. The Fungicide Resistance Action Group is a mostly industry-funded entity, but we need to make sure that this is included much more into the whole One Health thing. So in summary, I think we need to have some sort of global tracking of fungal pathogens of people, global tracking of resistance of fungi. The soil microbiome is a really important aspect which needs to be incorporated into the One Health to see what's going on in the soil microbiome. And a One Health surveillance lab should be set up, and then plant diseases should be incorporated in there as well. So it may seem an unlikely blend, but this is a really important thing, the fact that plant diseases are incorporated into a One Health lab. And if it's not possible for low middle income countries to do their own testing of plant pathogens, then possibly there should be some sort of global setup whereby they can be sent to regional centers for testing. One of the real problems that we have in the plant sector is that that effectively the medicines or the chemicals which are being used by untrained people, and there is no record of how much is being used at all. So in terms of surveillance, it would be incredibly helpful if we could just keep a track of which chemicals are being used against which diseases and in which combination. And if we have that data, it would be much easier to start to monitor the relationship between fungicide resistance, antibiotic resistance in the crop sector and how it spreads into a One Health scenario. So thank you.
Thank you very much, Phil. It's really important what you are mentioning, because this sector is really one of the neglected sectors that we need to really address. And all this what you mentioned is really important to, and this research agenda is addressing that. I think that this is very good research agenda for this specific sector. It's not just because the sector, but also the pathogens involved. You know that we know a lot of, you mentioned fungal infection and antifungal use in plants, but we don't know, we don't have enough information about antibacterials in the plants. So it's really an area and sector that we need to address. And thank you for all these ideas and comments, because this is important how the countries should consider this sector and include for an integrated surveillance, One Health integrated surveillance. I will move on to the next panelist. Thank you, Phil, again. We have Michael Omodo. He's a Chief Laboratory Technician in the Department of Disease Control and Environment Health of the School of Public Health at the Makerere University in Uganda. He holds a master's degree in the field of biomedical science and laboratory management, a bachelor degree in biomedical laboratory technology from the Makerere University, and national diploma in animal husbandry. He is specialized in AMR, and he has a total of 18 years working in veterinary research and medical institutions and laboratory technologist and research scientist. Thank you, Michael, for joining us and for sharing your experience. So the question for you is how this One Health Priority Research Agenda can support the implementation of integrated surveillance in low and middle income countries. How you see, based on your experience and also expectations from this agenda coming from Uganda. Over to you, Michael.
Okay, thank you so much, Dr. Murphy. I think I'm audible enough.
Yes, we can hear you.
Okay, thank you so much. Well, I'm going to begin with experiences from Ugandan perspective, and I'll go on to how this agenda can support in integrated surveillance. First of all, currently Uganda has no national action plan for antimicrobial resistance. The previous one expired, so we are just developing another NAP. And that one is going to range from 2024 to 2029. Then another challenge that comes with the implementation of integrated surveillance in our country is that the sectors that are supposed to synergize, they are working in silos, which is a very big hindrance to fighting antimicrobial resistance as a single individual. We look at, we don't have what we call integrated surveillance systems for AMU and AMR data. You find that sectors have the data, they are keeping it to themselves, they are not putting it into action. That makes it a big problem for us to do what? To move forward. Then another thing is the need to clarify on reporting procedures for AMU, AMR findings. There is actually a gap on reporting mechanism in our countries. And sincerely, without reporting, without sharing this information, trickling it up to the international community, we will not win this battle alone. Then, as a country, what is happening now? The One Health National Platform is reviewing the One Health Memorandum of Understanding. That is the memorandum that binds Ministry of Agriculture, Water and Environment, Ministry of Health. So that one is, there are also some gaps. They want to improve it better. Then you find that if we are to engage ourselves in meaningful integrated surveillance to fight AMR and control overuse of antibiotics, there is a need for our sectors to communicate, collaborate, and coordinate. Those three C's are lacking, and they are very, very important. If the sectors are cooperate, then I'm sure we will overcome this battle. Then the link with the research. And research needs to collaborate if it comes to development of one health policy, stroke one health policy law. We don't have one health policy law in our country. So research has been a bit left out. And yet without policies, we cannot get this funding. Governments cannot commit on supporting integrated surveillance programs. Then there is a need for capacity building sessions, both at the national and at the regional level. For example, we have what we call districts in Uganda, where we have the district veterinary officers. These are the officers that manage veterinary departments. They have been left out at the national level. So they need to be included in the One Health coordination office to be part of the One Health. Then there is actually, honestly speaking, one of the hindering factors, which is major, that has hindered the take of integrated surveillance of AMR in our country is lack of funding. Thank God for Fleming Fund. Fleming Fund came on board. They supported us. They strengthened our surveillance systems by building capacity and equipping our labs, which is okay. But again, I ask myself a question. What if Fleming Fund goes away completely? What next? You see? So there are a lot of things that we think about that need to be connected to fight AMR. Then another thing that I've realized, we have lack of standardized surveillance protocols. Health, if they want to carry out an investigation, they have their own surveillance protocol. Ministry of Agriculture, they have their own surveillance protocol. Unfortunately, environment, nothing much is done. And yet, environment is a black box for antimicrobial resistance. We need to think carefully about it. And then coming to your question on how AMR One Health Priority Research Agenda can support implementation of integrated surveillance in the low and middle-income countries. One, this agenda can support by guiding governments on the minimum requirements for designing an efficient integrated surveillance program, specifically for AMR and AMU. Then another thing, how this agenda can support LMICs in developing standardized, integrated laboratory and surveillance protocols. We need something that can speak one language. If it means data collection, if it means field work, if it means data analysis, we need One Health to be at the forefront. Then we also think that this agenda is very good, that it will support in guidance of standards for laboratory testing methods, including primary isolation, bacteria identification, and then the component of quality assurance is very important. You find that sometimes the QC strains are not there, but people are doing work. So how can you measure that kind of finding against what? So all those are our expectations, the support we expect to get from this agenda. Then we also expect this agenda to promote communication, coordination, collaboration, and then capacity building. Then another thing is to provide the tools that are needed to support AMR surveillance that can be customized by individual countries. We had the glass. Actually, we learned a lot. We got information from there and customized it. We did the first work. That is good. But now, here we have what we call quadripartite. It's a bigger picture. Global bodies coming up together to be one to fight AMR. Then another thing is this agenda can support LMICs by establishing a global, integrated, and harmonized AMR surveillance system, not program. I'm talking about a system here. Then also having a free, integrated, and standardized data analysis package that can be easily understood, that can be easily used to manipulate AMR data or AMU data. Then to ensure that countries have approved NAP for AMR that fully cover all the sectors and disciplines, and they are functional. Previously, when I was opening up my discussion, I told you we don't have any functional NAP. The one we had expired in 2023. So now the National One Health platform is back again conducting meetings on how to come up with another NAP. My thinking is also that because of the funding, I think there is a need for funders or donors to invest in areas like building research capacity across all disciplines. Then another thing is to propose parameters, because from above, from your experience, I trust that quadripartite can guide what parameters to look for when it comes to integrated surveillance. The data analysis package, I mentioned about it, and then the reporting methods that follow these findings to be compared with, and they should be, the findings should be compared within the sectors, the disciplines, within a country, and between countries.
Okay, thank you very much, Michael. This is really
Let me ask another.
Yes.
Hello.
We need to move to the next.
Let me ask another question.
Yes,
How
please.
can the limited availability of data from integrated
This is the
surveillance
next
be
question.
addressed in LMIC countries? One, by improving on the coverage of AMR surveillance programs. We need to incorporate the missing link, that is the environment. When you go for these meetings, they present about their fragmented data, AMR data from the medical sector, majority of it, as little data from the veterinary sector, and in the environment, it is not there a little bit. Then capacity building in data collection and data analysis. We need to have standardized, skilled people to do that. Then emphasize on the importance of quality data generation and strengthen AMR, stock AMU data sharing. Then promote quality assurance in data collection across all countries that are affected by AMR. Maintain and service of microbiology equipments, because without these equipments, honestly, we cannot pick this data. Thank God for Fleming Fund that supported some national labs, but the bigger part of the country has got issues with equipments. Then investing in consumables and reagents to obtain quality laboratory data. Improving on the utilization of microbiology services. Our services for microbiology are underutilized actually. That is why we have limited data. That's why we don't even see data which is in the form of integration from all the sectors. Then
thank you.
My expectations from the AMR One Health Priority Research Agenda is that these countries will have a robust surveillance system in place, better AMR One Health surveillance programs, improved data, that is to say, good quality data, then improved collaboration among disciplines and sectors. I would like to conclude by saying that without the participation and the collaboration of the international community, it is impossible, very impossible, to mitigate the health, the economic, and the environmental negative impacts created by AMR. Thank you so much.
Thank you very much, Michael. This is really important what you are mentioned. You were from the challenges that low and middle income countries have facing to address AMR, but also the opportunities of this research agenda to help and support governance, but also how to deal with the main challenges at the field level. Thank you very much. This is really, really important and interesting to address by low and middle income countries. We will continue with the next panelist. She's Rontip Chuanchuan. She's a veterinarian professor at the Faculty of Veterinary Science in Chulalongkorn University in Thailand. She's leading the FAO Reference Center for AMR. Her research focuses on molecular epidemiology and resistant mechanism in bacteria of veterinary public health importance using One Health approach. Thank you, Rontip, for joining and sharing your experience. Basically, I would like to, Michael already highlights some of the challenges, but based on your experience, what do you think, what is the other challenges that you have faced implementing research activities and integrated surveillance in low and middle income countries? Over to you.
Okay, thank you, Jorge. So you know what, I always think that I am very lucky, to have a chance to visit many countries and also be part of their national capacity building for their national AMR surveillance. And based on my experience, I found that the main challenges for research implementation are different from one country to another, depending on country development. And there are multiple reasons, for research activity being done or not being done. But however, they share some common. For example, research initiatives on integrated surveillance are not a priority in many countries, where the priority has been given in favor of food safety, animal health, disease treatment and prevention, or like a herd health management. And this is exacerbated by the fact that AMR is still not a priority in some countries. And now there is no conclusive proof about the use and the benefits of research finding and the data generated by integrated surveillance. And also there is still the lack or limited capacity of national surveillance for AMR and AMU in these sectors. So it is a little bit far, or maybe quite far, for integrated surveillance in many countries. And actually, right now, there are quite a number of ongoing research in different countries and in different topics, okay? But many of these countries have limited infrastructures and resources necessary for high quality research. And the availability of research-focused fundings is also a challenge. Many countries may have governmental or institutional funding, but it is not sufficient. And of course, not all is for integrated surveillance. And this limitation affects overall research initiatives and implementation, not just only for integrated surveillance. And also, another important problem is the lack of trained personnel and laboratory facilities. Okay, the local researchers may not have a comprehensive understanding of the importance and unique opportunities of integrated surveillance. I also think that among these challenges, there are also opportunities, okay, especially for researchers, okay? There is an opening chance for those researchers from developed and developing countries to work together, and then can also work with organizations and institutions towards the implementations of research activities. And I think a good example is like, the training and mentorship opportunities, that could be one of the starting points. So that is all my questions, answers. Yeah, thank you.
Thank you so much, Rontip. This is really interesting and important. I agree with you with the challenges, sustainability, and the lack of priority for research in many countries, mainly for these specific topics, but also this research agenda you are highlighting that is an opportunity to create this partnership with research institutions and high-income countries and support not only research, but also to build capacity in countries. So this is really interesting and important. Thank you so much. I will move to the second round of questions, but please, I will ask the panelists if you can just take 2 minutes to answer the questions. Thank you. Sabiha, your next question is, how could international guidance benefit from this One Health Priority Research Agenda? What is your thoughts about it? Over to you.
Sure. So thank you, Jorge. So this morning, Elizabeth contextualized this particular pillar as one of the 5 pillars of the research priority agenda. And we also spoke about the research questions on methodology, operationalization, and monitoring and evaluation. Now, as is customary, global priority agendas and action plans of the quadripartite are always accompanied by guidelines or implementation plans. And we recently saw the guideline to implementing the One Health Joint Action Plan on at a national level. So as I mentioned earlier, the quadripartite has appointed a quadripartite technical group of AMR and AMU integrated surveillance who have developed a purpose-based definition of integrated surveillance and is in the process of finalizing a guide for the implementation of integrated surveillance at national level. So Michael alluded to the need for such a guide, and Michael, watch the space, it's almost ready. So the guide covers sampling and data management, including a sampling frame and sampling sources, sample size calculations, representativeness, frequency, quality assured, standard operating procedures for sampling and laboratory investigations, integrated and triangulated analysis, which is really important, as well as the interpretation and communication of this analysis to inform action by policymakers and other stakeholders. So remember that surveillance is meant to be using the data for action and the action to mitigate AMR. The guide also identifies parameters for harmonization. We do know that we require some kind of harmonization to allow comparability. It speaks about harmonization, standardization, and comparability of AMR and AMU surveillance data. And we're also looking at minimal epidemiological and metadata requirements, as well as indicators, resources, and considerations for implementation and operationalization. So this is going to be a comprehensive document that has both the theory and the practical aspects of it. And I think a number of the people on the quadripartite working group are on this webinar, and several others are listening in, and I'd like to shout out to them and thank them for all of their hard work. I really want to emphasize the last point, Jorge, that surveillance data is meant to inform action. And the development, implementation, and evaluation of policy and practice interventions to mitigate AMR at One Health interfaces. So thank you.
Thank you very much, Sabiha. And thank you for sharing this, because I think that will be really important, this new guidance that quadripartite is developing, but also how this research agenda can be benefit to also include some of these aspects in this new guidance that is on the development. Caroli, a second question for you. Based on your experience, we talk about sharing data. What are the most reliable approaches for sharing AMR and AMU data in different resource settings? Over to you.
Thank you very much. And I'd like to follow on Sabiha's comment that surveillance is data for action. So you need to get the information coming out of integrated surveillance in the right type of content to the right people in the right way. So the right type of content is about delivering the information or translating it in ways that the target audience who can take action understand it. Antimicrobial use and antimicrobial resistance is a very technical subject matter area, and it can be hard to understand. So, for example, some of the antimicrobial use metrics are quite complex, and it could be something like number of defined daily doses per 1,000 chicken days at risk. So this is a dose-based metric that has a big name to it. It's quite an important metric when we're understanding the epidemiology and analysis of trends over times or relationships with resistance. But a farmer might be more interested in just simply knowing whether antimicrobial use increased or decreased, or how they compare to the local average use in that region. So the content should be designed to have the best uptake of the information to affect decision-making. One of our PhD students conducted research on what antimicrobial use metric were best received by swine veterinarians in Canada to improve how we reported our information and how to facilitate stewardship. What was interesting was that the participating swine vets actually preferred these complicated dose metrics, which wasn't what we had expected. However, this was how they wanted to receive the information, but they were more comfortable in explaining to their clients frequency or weight-based metrics, the more simple metrics. So it was that balance between how they wanted to receive it and how they wanted to relay the information. And we also found out how hard it was to get veterinarians and producers to participate in this type of research. So that's the right content. And Sabiha also mentioned context and stakeholder mapping. So this comes to the right people and knowing who your stakeholders are. And that sounds very simple, but I can tell you we put effort every year in refining our contact list. So developing and maintaining that network of those working in the field and who can make decisions, and also who are the trusted conveyors of the information. So often we are a national surveillance system and we deliver the information. Our contacts are mostly with the national or provincial level representations of public health, or the different animal species groups and the different animal veterinary groups. And so we rely also on them to convey our information within their sectors. They are trusted conveyors of that information within their sectors. And delivering the message in the right way. So we had another PhD research project that looked at veterinary students and medical students and found out how and what they knew about antimicrobial resistance and how they wanted to receive information about antimicrobial resistance. And they actually really liked in-depth fact sheets as opposed to peer-reviewed publications and as opposed to infographics to give them the depth of knowledge that they would feel comfortable with. But they felt infographics were quite useful and visual, again, for conveying to their clients. So it's, again, that balance of what they wanted to receive the information and how they wanted to convey the information. And in terms of about this trusted source, I spoke mostly about data conveyance out of the surveillance program, but in terms of data collection into the surveillance program, speaking as one example from farms, it needs to be collected in the right way by the right people as well. So for most of our terrestrial farm surveillance, it's the veterinarian of that farm that administers our questionnaire and collects the samples from the farmers. And why this works is that it minimizes things like biosecurity concerns. So that's their veterinarian rather than a stranger, maybe from the government, coming onto that farm to collect the information. And also the veterinarian is a trusted party by that farmer as opposed to, again, a stranger. So in conclusion, for me, it speaks to the right type of content to the right people and the right way. Thanks.
Thank you very much, Carolee. This is really important. We know that surveillance is information for action, but also we need to be careful. It's not just to collect data, right? It's how we are going to get this action and how we can involve the different audience collecting this data. It's really important to consider this for integrated surveillance. Thank you very much. I will move to the next question for Phil. Phil, could innovation and emerging technologies accelerate the process of plant sector integration and integrated surveillance? Over to you.
Yeah, thank you. This is an interesting one, and I've thought about this a lot, and I've inquired to many colleagues on this one as to how to answer it. And it's a tricky one because the surveillance is of plant pathogens is an ongoing thing, but it's often done by untrained people. This is one of the problems we have. Whereas in a medical field, you have people who are trained, people who are doctors, who have done an extensive amount of training. Whereas in an agricultural crop environment, it's often poorly trained people or the farmers themselves who've had very little training, who are doing the diagnosis and looking for antimicrobial resistance. And it's a problem because the often the doses which are put on by the farmers have been miscalculated, and as there is with medicinal drugs, sometimes counterfeit materials get in the way as well. But there are new technologies emerging. There are these automated spore traps which will trap spores, suck in air or trap spores, and they will do PCR in the field, automated it, and looking for different diseases. And you could imagine that it wouldn't be that much harder to start looking for antimicrobial resistance. It would be something I couldn't do, but it's the kind of thing that will be coming, I imagine, with time, whereby people will have automated spore traps and will be able to not only identify the fungus or the fungus which has actually produced the spore, but it may be able to look for resistance as well. So this is some way off, but it's an exciting development which may occur. But other than that, we are reliant on the medics and the veterinarians to produce these techniques. And in some regards, not always, but in some regards, the crop production people will be playing catch up with them as well. So sorry to be a little downbeat on the question, but I think that's the reality of the situation.
Thank you so much. No, this is also interesting because and important because we also need to consider not just the innovation and coming technologies, but how can be implemented in the field. We need to consider many other things.
Mm-hmm.
I will move to the last question to Rontip. Rontip, in your experience, what are the minimum criteria and indicators to improve integrated surveillance across sectors in low and middle income countries? Over to you.
Yeah, okay, so we are talking about research to improve integrated surveillance, right? So I think it is very straightforward that the minimum criteria are having national AMR surveillance in place in each sectors. So if not, at least the capacity should be being built. And this indicates that the capacity of AMR data generations has been built at a certain level. And this will also form the basis for promoting to integrated surveillance. And the fact is that things change and priorities change. So it is very important that each country uses an evaluation tool to ensure that the current program are fit to the purpose and also cost effective. And right now, there are several evaluation tools available. For example, on the top of my head is AMR PMP, okay, which is the Progressive Management Pathway designed by FAO. And this tool provides guidance to countries for operationalizing their national action plan for AMR step by step, and also, of course, using the One Health approach. And for the indicators, I think these depend on the purpose, okay, for what to be measured, okay? And I think the simple way could be those that suggested for monitoring and evaluating implementation in class. Okay, so you can just go in there and just look, okay, because these could, help to estimate the extent and burdens of AMR across sectors, as well as the progress of the program. Okay, for example, there could be the number of prioritized specimens and pathogens included in integrated surveillance. Okay, the number of AMR surveillance sites that collects and report the AMR data. Also, the proportions of clinical staff, surveillance staff, laboratory staff who are trained in integrated AMR surveillance system. And importantly, okay, it is the proportions of surveillance sites that submitted surveillance report to the next level, okay, within the surveillance reports. Yeah, so that's pretty much for me.
Thank you very much, Rontip. This is really useful. And also important, not just to consider minimal criteria, but also to see the system, how to build the system, how to evolve the system, as Carolee also mentioned, and how was the experience in Canada. So thank you very much, all the panelists. I will move now to Francesca, to the Q&A session.
Thank you very much, Jorge. Yes, so at the moment we do have two questions posted there. So one, the first one, it is for Mark Sobsey, and we'll address it to Sabia. So is the WHO Tricycle project for ESP and E. coli considering integrated multi-sector One Health surveillance framework and system? And can this system be expanded and adapted as needed? So Sabia, for you, since you have those experience.
Thank you very much. I did mention it in one of my responses. So Mark, the WHO Tricycle project or Tricycle project is indeed an example of how to conduct integrated One Health surveillance, although it has some limitations. And for those that are not familiar with the project, basically this project uses extended spectrum beta-lactamase producing E. coli as a single indicator for integrated multi-sectoral surveillance. And the protocol includes standardized methodologies for surveillance in the human, food chain, and environment sectors, taking cognizance of low resource settings. As I mentioned, it has limitations. There is minimal guidance on integrating the integration and analysis of results. And we again see that some of the work is undertaken in sector silos, and there are gaps related to analysis of the interface, transmission dynamics, and risk analysis. So these are a few of the things that require augmentation in this protocol. So the Tricycle project was the focus of a JPI-AMR network, and you may be aware of this, the NETEAS network, which is the Network for Enhancing Tricycle ESBL Surveillance Efficiency, I think. And this network has made recommendations to optimize the Tricycle project. So we, as the quadripartite technical group on AMR and AMU, are adapting this project to the integrated surveillance framework and guidance as an illustrative example. So as the quadripartite group, we don't want to reinvent the wheel. We looked at excellent examples of integrated surveillance and have adapted them according to the enhanced parameters, protocols, and framework that we've come up with as a quadripartite group. So yeah, thank you. Thank you, Francesca.
Thank you very much, Sabia. And now we do have another question, which is more referring on like what it is the country are reporting. So basically there is like an increased number of countries that is reporting that some activity or integrated surveillance is going on. Reporting in, you might be aware of the tracks, so which is the tracking AMR country self-assessment, which is compiled every year. So in this context, so what, how we can work with countries, or how can countries work within themselves to continue engaging integrated surveillance to may not be at the ideal level of integration at the same level.
Thanks very much, Francesca. The experience of Canada was when we first started our, excuse me, our integrated surveillance program. We had a plan, but it was very patchy and it was very, we could barely call it integrated when we got started. We had some human surveillance of AMR and Salmonella. We had some pilot projects on animal food, and we had 4 months of abattoir data and some diagnostic isolates on the veterinary side. And that was it. The simple fact of starting the surveillance program, releasing the data, talking to people about the data, we received a lot of comments and questions about our work, criticisms, and sometimes our biggest critics gave us the leverage to seek new opportunities for funding, to prioritize when opportunities arose, to explore new data sources, so that context and stakeholder mapping, we could go to the stakeholders and say, we've been criticized for not having this in our program. Do you have any data that would, you know, partially fit or fit the needs we have there? And then over time, we worked to refine the data sources, the coverage, and the scope. So our first report was it was not a complicated integration. It was simply a summary of what we knew in those existing different components that we have. But that beginning is so critical to get started. It will drive the questions and continue to seek the opportunities to refine it. Thank you.
Thank you very much, Carolee. So, and now I think that we can actually conclude this session, and then just like, I would like again to thank you all the different panelists, of course, like the name on behalf of the of all of us, quadripartite, and then just maybe to summarize. So I think that we can see like there are still a lot of gaps that exist when it comes to integrated surveillance methodology. So we see like there are like a lot of persons that in the research agenda, they try to make the point that these still need to be addressed. And of course, this is even more needed for the new sector that they are coming to the picture. So for the plant, as we have been hearing from Philip, but also like from the environmental sector. Then I think that we can also see that there are challenges, of course, more important for the funding opportunity to conduct research, which can be useful in low and middle income countries. And this was quite clear from the presentation, like from the intervention from Rumtip and also from Michael and also Sabia. I think that in general, these, in any case, it could not be a limit, a big limitation. I think that there are opportunities right there, and I think that we hope that this document also try to help to advocate for more funds in this sense. Then I actually would like to conclude that, well, research, it is quite important. It's very important for surveillance. And I think that Caroline has shown very clearly for Canada, which is one of the countries that has implemented the integrated surveillance quite for a long time now. It is a continuous loop. Research feed, the research studies feed has fed the surveillance protocol, and they are still helping to refine that, including also the communication, which is, as we always say, it is information for action surveillance. And if it is not targeted in the right way, people will not use it. So with this, I really would like to conclude this webinar and remind you that the next one will be the 7th of February and will be on the intervention pillar. Thank you very much, and I hope that you find it useful. Bye.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you very much. Goodbye.
Thanks. Bye-bye.
Bye.